Hello and welcome to the third webinar on mental health and COVID-19. My name is Niall Boyce. I'm the editor of The Lancet Psychiatry, and I'm here today with an expert panel, and we're going to be talking about mental health and COVID-19. What research do we need now, and what should we measure for the longer term? So before I introduce our panel, I'll just like to remind everyone that this session is being recorded. If you're on Twitter, please use the hashtag COVID-19MH. And we encourage you to tweet throughout. So our panelists today are Edward Bullmore from Cambridge University, Emily Holmes from the Karolinska in Sweden. We're also very pleased to be joined by Lola Kola from the University of Ibadan, Nigeria, and Mark von Ommeran from WHO, as well as Charlene Sunkel from South Africa. So what we're going to do is just start off by talking to each of our panelists in turn about their specialist area, and then we'll move on to some more general questions for the panelists, including one or two questions which you have sent in. So the first person I'd like to turn to is Mark. And Mark, I wonder, you have experience of researching crisis situations, of which this is one. I wonder what challenges there are in doing research under the sorts of circumstances in which we now find ourselves.
Good afternoon, Neil. Good afternoon, everybody. The challenges in general in research in emergencies is access. So it's getting access to the population in an ethical way. That's probably the number one challenge. The second, so that's it's logistical and ethical challenge often. The second challenge is very often is distinguishing between very often when we do mental health research, we are very interested in mental health conditions, mental disorders, and in a background where there's so much to be expected, sadness and anxiety about which is not excessive. It's more difficult to distinguish mental health conditions from natural to the expected distress. And that's a big challenge, and it often leads to unusual findings when we do epidemiological research, for example.
Okay, so it strikes me that can make it quite difficult to prioritize, to find what things we should really be targeting now. So from your point of view, what should our priorities be in the immediate term?
Well, from a research perspective, what the public health community in general would love to see is how the mental health community can contribute to the overall COVID response, making sure to control the disease. So anxiety and fear are without doubt widespread, and they're not necessarily helpful. Sometimes they're helpful, but not always helpful to following good suggestions by health authorities. So an immediate answer that the public health decision makers would love to have from us is how do we deal with this public anxiety in a way that right tomorrow we can handle this response in a more effective way. And and for us, of course, from a mental health community perspective, we often find, and so do I, that acting on mental health is good enough. You know, if we just act on mental health and we improve mental health, that is good enough. And that is not. We don't necessarily need to prove that we can control the disease. That's not what we're after. But I think the public health decision makers would like us to show that we can, and I think many of us think we can, but we don't have the very crisp data, direct data, to show that our actions working on mental health, we can help with the public health response.
So it sounds to me as if you're saying it's not the case that there's infection control in one category and then there's mental health in another category, but the two have to really work together, and that gathering good data is part of that.
That's right.
Okay, so this leads us on very nicely to Emily. Now, Emily and Ed were authors on a paper which the Lancet Psychiatry published last week, which was on research priority setting in mental health in the COVID-19 pandemic. And Emily, I wonder if you could talk us through some of the specific psychological and social research priorities which you and the team felt were important in this paper.
Thank you, Niall. And obviously, in making these priorities, I want to start by saying a huge thank you to our 24 co-authors who contributed to this. It's not easy, just as Mark was saying, deciding exactly what priorities are. So what we've tried to do is think about the immediate priorities, things we need to do now, and the longer term priorities, things that we need to start doing now in order to think about mental health in the long term. And following on very nicely really from what Mark just said from WHO, we're very mindful that these are times we need to think about mental health on a continuum, because lots of reactions may be part of human distress, and we need to understand how this is evolving. First of all, a priority is about monitoring, understanding the data, and seeing how patterns emerge over time. So in all good research, we need good, ethically collected data with high quality standards. And that's the baseline for collecting information. But I think what we also need alongside that is a balance of what's difficult and also what's helping people cope. So in terms of psychological factors, what we've tried to do is tease apart those two. What are individual difficulties, but what are also things we can learn about resilience and coping under pandemic conditions? And I think if we turn to a more, rather than individual focus level, to a more societal level, that again ties in with the kind of questions that Mark was raising, because we've got immediate issues like how do we help the vulnerable groups who we are concerned have, for example, an existing mental health problem and they need support, accessing services in a new way under pandemic conditions or at risk of relapse. And we can talk more about vulnerable groups if that's interesting later. But also, there's something that's around what this pandemic is doing to us at a more societal level in terms of our emotions and behaviours. And two priorities that we've pulled forward are trying to think about, this is one of the first times we've had 24/7 pandemic-related media exposure. Now, some of that's essential. We need to keep updated, but some of that looks like it's fueling our anxiety. So an immediate priority needs to be understanding and working on that. And the second pandemic-related social level thing, again, very much related to what we've just heard from the WHO, is health behavior messaging. So we know from previous pandemics, health behavior messaging works when people feel anxious to a certain amount, they might act on it. But we also know, or we're starting to see, if they're too anxious, they may be less likely to act on it. So here's something the research community really needs to grapple with, and as soon as possible, so we can optimize health behaviors. And the last thing I want to say is that optimizing those behaviors might not just only help our mental health, they may also help curb the spread of the pandemic itself.
So I mean, it's good to know that mental health can play a role in that, but I just wonder about the business of evidence. You know, what evidence do we have that you know, better knowledge of things like health messaging, of the sort of psychological research which you're talking about? Is the evidence base particularly strong at the moment? And if not, is there a need to gather more data? And if so, isn't this something we should be getting on with, like right now?
It's absolutely urgent, because we want to be getting on with it now so we're prepared for the next wave. I think that what we've talked about in the paper is trying to think about what disciplines need to come in and help mental health right now, and it's multiple disciplines. So in our author list, we include, for example, Professor Roxanne Cohen-Silver from America, who's an expert who's shown that viewing lots of anxiety-provoking media has a, let's say, a direct correlation to worsening people's anxiety and mental health. Now, if we know that's the case, the next question is research on how to mitigate that consumption. We had, for example, Professor Susan Michie, an expert in promoting health behaviours, also talk about the need for really unpacking those with behavioural research to optimise how people act on, for example, how hand washing advice could be different types of advice, but also keep our anxiety in control so it's used. So Absolutely. I think there's a huge role to play for social sciences research informed by lived experience of people receiving these messages targeted at different age groups. People might react very differently, and that's what we've learned from working with people from lived experience. How do we need to tailor that messaging?
Thank you, Emily. Now, it's a measure of how quickly research runs that a paper which I know we were looking at a few weeks ago as a preprint has now been published in JAMA Neurology, which is this paper, an initial report, really a very large case series of neurological complications of COVID-19. And this is where I'd like to bring in Ed. Is this something that we should be concerned about, the potential effect of the virus on the brain and hence, of course, on mental health? And if so, what sort of research should we be prioritizing?
Well, thank you, Niall. So yeah, I mean, I think if you step back and you just think, well, what's going to be the impact of COVID on mental health? One way of thinking about it is what are going to be the effects of the infection and what are going to be the effects of the social response to infection. And you know, media and social isolation and so on belong in terms of the response to the infection. But what about the infection itself? And I have to say at the outset, things are moving fast, as you say, Niall, but there's still an awful lot we don't know. And one of the things we tried to do in the paper was say, well, here are some of the things that we think we know at the moment, and here are the things that we still need to know. What are the things that we think we know at the moment? And I'd say there are two big things that we think we know at the moment. One is that neurological presentations are surprisingly frequent in association with COVID. That's one thing. And the second thing we know is that other coronaviruses that are genetically similar to SARS-CoV-2 have demonstrated neurotropism and neurotoxicity in the past. Neurotropism meaning that they can get into the nervous system. Now, let me just say a little bit more about those two things. The neurological presentations that are being reported as a complication of COVID, there's the paper you mentioned, Niall, in JAMA Neurology. That's the biggest and most comprehensive of them so far. They found about a third of COVID patients had some sort of neurological symptoms which ranged from headache and dizziness through loss of taste and smell to some quite severe neurological presentations, including delirium and stroke or seizure. France, there was a paper, short report, just came out in New England Journal of Medicine a couple of days ago, pointing to several ICU patients who had quite severe neurological symptoms, agitation, confusion, quite a lot of so-called dysexecutive syndrome in ICU survivors. In other words, impaired cognitive function in people who'd been through ICU and come out the other end. And in Italy, just recently, a series of 5 cases of Guillain-Barré syndrome were reported in relation to COVID. And Guillain-Barré, as people may know, is an autoimmune disorder of the nervous system that's triggered by infections. So there's quite a lot of these sort of case reports emerging. What we don't know at the moment is what causes these neurological presentations. You know, there's a lot of relatively non-specific things happening to the brain, particularly in the more severely ill patients. You know, they may be hypoxic, they may be on a lot of drugs, they may have disorders of blood coagulation which contribute to strokes and cerebral ischemia. All of that could contribute to the neurological presentation, but it's not particularly specific to the infection. Then there are the inflammatory response of the body. The cytokine storms that are associated with COVID are known to change behavior and change brain function. There are the more specific immune mechanisms, these sort of para-infectious or autoimmune syndromes like Guillain-Barré. A lot of people think that that's quite a likely prospect at the moment. And then the last possibility is that the virus actually gets into the brain. And what we're seeing in some of these cases may be a reflection of brain infection. I have to say the evidence for this virus getting into the human brain so far is just about as slim an evidence base as it's possible to get. I can only find one case report, and that was published in Chinese. I haven't read it myself. One case report from China of a post-mortem brain, which showed that the virus had got into the nerve cells there. I think that's the most clear-cut evidence, but obviously very limited. So that's what we know clinically, and then we know a lot of work from other coronaviruses to suggest that this virus, SARS-CoV-2, might share their properties of being able to get into the brain and cause problems in that respect. So that's kind of what we know. What we don't know is obviously still a long list. And in the paper that we published in the Lancet Psychiatry, we highlighted a couple of immediate actions. First of all, we need better data. We need more comprehensive clinical data sets of large cohorts of COVID-19 patients, not just the most severely ill. Ideally, that we can follow up over time so we can see how symptoms, neurological and psychological symptoms, evolve over the course of time after infection. We need to build capacity to look at brain tissue post-mortem, because that's such an important part of nailing the question of viral infection. And those are things that we could begin to work on immediately. In the longer term, there's a lot to do, and we summarize that in three big buckets, really. Mechanism, so understanding why these neuropsychological presentations are occurring, and I've spoken to a bit of that already. Biomarkers, we really need clinical tests of how the infection is impacting on the brain and on mental health in that way. And then, of course, interventions, and that will depend on a clearer understanding of mechanism. But in the existing literature, as we highlighted in the paper, there's already a lot of interest in the idea of repurposing drugs that might already be out there, licensed for other indications, and could relatively quickly be repurposed for COVID, but particularly COVID as it impacts on brain and mental health biologically. So I think that's sort of where we've got to at the moment. There's definitely growing interest in the field, I would say, about what is being called neuro-COVID. The mental health implications of that are frankly unknown at the moment, but it seems wise now to be thinking about them and to be taking steps to build the kind of data and the kind of research programs that we need to fill in some of the gaps.
Thank you, Ed. Now this leads me very, very nicely to Lola now. Emily, you've talked about psychological research and psychological interventions. Ed, we're talking about potentially down the road repurposing drugs to treat potential neurological complications. But whatever interventions we have, they then need to be implemented and potentially implemented at some scale. So Lola, I'd like to know if you think that we also maybe need some research into health systems and implementation of research in response to crisis here.
Thank you very much, and for inviting me to participate as a panelist on this discussion. Now, I would like to start by saying that COVID-19 pandemic challenges the very fabric of our societies and has caused significant disruptions to service delivery, not only in Nigeria, but every part of the world. These disruptions have mental health implications, of course, like we know, not only for the patient accessing psychiatric services, for example, but also for the elderly patient needing dental care in the UK, or even the perinatal adolescent in Nigeria accessing care in primary care. So it's very vital that we invest in building resilient health systems to withstand this kind of pandemic and its effect. Research into health system and implementation, of course, like we know, will allow us to identify, study, and address targeted problems in part of all the 6 building blocks of our healthcare system. And this is crucial for coverage and success of proven mental health interventions. Typically in low and middle income countries, we have very limited services, and we know from several task shifting initiatives that they're successful interventions. But widespread use of successful interventions have been hampered by implementation problems. Now, while there is very important that new innovations come up, it is also crucial that we address barriers to scale up of successful interventions with health system and implementation studies, For example, task shifting that is well talked about in low and middle income countries can only be impactful if other crucial parts of the health system are working. This is important because COVID-19 will amplify the existing treatment gap, particularly in low and middle income countries in the coming months. In Africa, this global pandemic with huge mental health needs intersects with highly fragmented, under-resourced healthcare systems. And as we know, social economic effects of social distancing, social isolation, and general restriction of movement have very, very severe implications on mental health of the individuals. Now, with the urgency for action that COVID presents to global mental health research, there is need for innovative strategies to implement new and existing interventions to scale up care. As we think of these strategies within the global mental health context, both now and even during the COVID stages of this intervention, one thing is very clear, that reliance on face-to-face model of care is grossly insufficient to get the job done. It is imperative, therefore, that we begin to think outside the box, not only in less resourced countries, but even in developed countries. In a recent world report published in The Lancet, I think 2 weeks ago, by Dr. Peter Weber, we learned that physicians are embracing virtual care like never before. Though this is happening now for COVID-19, in the future, there will always be reasons why the therapist and the patient cannot be in the same room. In Africa, for instance, we have intermittent outbreak of infectious diseases. We have cholera, we have Ebola, now COVID-19. There will always be reasons, including conflict, geopolitical reasons, or even common day-to-day barriers that hinder access to mental health care. Now, mobile phones are everywhere, not only in developed countries, but even in the remote countries of Africa. They are evidence of their effectiveness, and now we are presented with opportunities to come up with strategies to overcome implementation barriers and mental health, to bring mental health to scale, particularly in low resource settings, where the impact of this, mental health impact of COVID-19 will be more felt in the many coming months. This, however, is not to undermine the benefits of face-to-face model of care, but to convince us of the need to add technological scaffolding to our implementation strategy for greater impact. For example, with adequate digital bandwidth, a clinician can effectively deliver PST to a patient on the mobile phone in a different location. What I'm trying to say here is that we need to think out of the box for our implementation strategies. Therefore, while African countries, for instance, do not have the same capacity to respond with alternatives to COVID-19 pandemic, like we have in the UK or even in the US, we are pretty much at par with access to mobile cellular infrastructure. Creative use of technology, therefore, has promise in assisting us as we identify, study, and address, and even reverse the mental health effects of COVID-19 that will show up in the different layers of our health system in the coming terms.
Thank you. And this is something which I hear from clinicians, psychologists, psychiatrists, other health professionals, which is a real emphasis on digital mental health as an important area of research, not just in response to this pandemic, but also really as a way in which we can take something out of here, which can build for the future. I know that in our first session a few weeks ago, Simon Wesley said that more has happened in the last few weeks in terms of moving along the implementation of digital mental health than had happened in the 10 years before that. But before we turn to more questions on the research side, I'd just like to bring in Charlene Sunkel, who is an individual who has lived experience. And Charlene, I wonder what you would say people with lived experience can bring to this conversation on research priorities and how we can make sure that the right voices are heard.
Thank you, Niall. Yeah, I think people with lived experience, of course, play a very critical role in research, not only as the targeted subjects, if I can put it that way, who must ultimately benefit from the outcomes, but they must be involved to inform research and also to give direction to the questions that we need to answer. And these, of course, range from impact on areas of recovery, stigma, human rights, the role of peer support and other interventions, and of course, as mentioned before, our previous panelist, communications technology. The lived experience community also further plays a role in data collection, the dissemination of evidence, and of course in the design or modification of interventions, but also in the monitoring and evaluation thereof. There's also a lot of lived experience researchers out there, which I think can add particular value to generate evidence and also to help develop interventions. So essentially, people with lived experience must be at the center of the research agenda. And in terms of making sure that the lived experience voices are heard, it is imperative that we involve diverse voices of people with lived experience within the specific context that in which they are, and they must be empowered. I think empowerment and support is very important in order for them to meaningfully participate, and also to give them the platform where they are able to share their needs and challenges and share their experiences during this time. I think COVID, for me especially, has been the one global event of such magnitude that I think most people never experienced before. So I think it's safe to kind of predict that this global pandemic will affect people in ways, and I feel that the world is not particularly prepared for. We already know and seen that mental health systems, even before COVID, was already severely underfunded and under-resourced. So in the area of service delivery, persons with lived experience are particularly able to offer valuable information and guidance, as they have particularly an extensive experience in navigating these systems. And I think it's important that we act now. At this point, research is critical, not only for the rapid response, but also for the aftermath of COVID. And we know COVID may pass, but the traces of it will potentially remain in people's lives for years to come due to various factors. We already seen an increase in people experiencing mental health problems. And what's for me is very concerning is people within mental health facilities or care homes being particularly vulnerable and often neglected. For me, this is a concern because we and countries have committed to the SDGs and not leaving anyone behind. I just want to make one final point to emphasize that peer support work is such a critical but under-recognized and undervalued service that could play such an essential component in the COVID response now and as well as going forward. And I think research in this field specifically is important and will raise the profile of people with lived experience as key partners in the response and in the development and execution of actions as well as interventions. Thanks.
Thank you, Charlene. I think that one of the messages which I'm getting from all the panel is that this research needs to be well thought through. We need to ask the right questions. We need to use the most robust methods and, of course, the highest ethical standards too. But might there be a conflict between this desire for robustness and quality and the urgency, the time pressure under which this research should be conducted? And that's where I'd like to bring Mark back in, who has experience in this area. Is there necessarily a trade-off between quality and speed? And if so, what can be done to negotiate this?
Thank you. We've written in the past a paper which has the title Relevance or Excellence. So I think relevant, you need both. Obviously, you need both. And I think there's some form of trade-off, yes. So the research needs to be absolutely good enough that we can do something with the findings. Absolutely. Otherwise, it's not ethical. But on the other hand, it must be relevant. So practically speaking, if you look at, for example, Emily Holmes' paper or other papers in the area of research setting in humanitarian settings, there's so many things to study, so many different components. It is a very big range, and all of it. And since we have many researchers and there's many people out there interested, and hopefully there will be good research funding, that whole breadth needs to be spread. At the same time, there are certain areas which right now are just calling out for immediate work. We talked a bit about the behavioral, about the messaging, the behavioral behavioral science, making sure that the messages are effective. And I learned years ago, and I'm not sure how much evidence I've heard now, that risk communication must be empathic. You should not only say to people, wash your hands, but you should say, you're very scared. Better way of saying, acknowledging people's fear of the epidemic, and then in an empathic way saying, well, given that you're maybe scared, hand washing will keep you safe. So it's a different way. So basically, that's just one example. Similar outside another topic is really the issue of that much of the infection is happening in places where people with mental health conditions are. In long-term care homes, people with dementia. And we've just seen this reported NBC last week in American. Tons of psychiatric institutions are infected. And and it's not a surprise. I mean, one of the first things we alerted in the house was that this is one of the places where it's very, very likely that people get infected. It's confinement. There's people maybe entering the hospital with a delirium without fever, but still COVID related. There might be all kinds of reasons why there's general neglect in many places, not all of them. I don't want to stereotype the mental hospitals, but there's often issues. So what can we do right now what research can be done right now to make sure that the hundreds and hundreds of mental hospitals in the world that are not being infected yet, and where the COVID outbreak is not very wide yet, are better protected? Should be very simple questions on how to deal with that. That's relevant.
Thank you, Emily. You look like you have something to add there.
Oh, I'm just agreeing with Mark says, and I think that fits exactly spot on with the call to do immediate research to look at the needs and act on the needs of vulnerable groups, including signposting to resources. And in addition to confinement, I'm just raising one of the things we raise in the paper, which we've worked with people with lived experience in discussing, but for some people under confinement, they're now spending more time at risk. So we're thinking particularly of people at risk of domestic violence, children at risk of various forms of neglect and abuse, as well as other forms of confinement. So this is really an urgent priority. And we really call on the research community to start addressing the needs of vulnerable groups.
And that again brings me to Charlene. I know that Charlene, a lot of your work in the past, thinking about people with lived experience, has been based around issues of equity. And is there a potential here that COVID-19 will reverse some of the gains which have been made in terms of equity for people living with mental health problems?
Yes, I definitely believe so. I think I think we need to push more for equality in health, overall health. Yeah. I think a lot of the concerns even that people were reporting, some of their fears was, will there at some point be a problem with accessing their chronic medication? And that in itself already puts people into a panic. Me, myself, are concerned about that. There's so much focus on the medical or physical medical side of COVID and so little on really paying attention on how it affects people with mental health conditions. I actually had a very interesting conversation with a few of my peers, and we were actually saying there's even some positive aspects of COVID being in lockdown. And some were saying, for example, especially with anxiety disorder, they don't need to have an excuse anymore to go socialize because lockdown is the reason. Others found that they had the time to kind of almost inspect themselves internally and learn more about themselves and actually what they want out of life. So there's really a range of experiences from the lived experience community. And I think it's very important to look at this. And when we come to designing interventions, that we make sure it really speaks to specific needs and challenges as identified by people with lived experience from their unique perspectives and experiences.
Yeah, so it's that deep knowledge of lived experience to really help address the complexities, I think, which is what I'm hearing from you. And I'd like to ask Lola really about the issue of, we can come up with this research, which will hopefully come up with strategies for public messaging and for psychological interventions and for even medical interventions. But what about sustaining this response once the pandemic is over and we're looking at the longer term consequences in terms of poverty and other social issues? How do we make sure that we keep this on the road? You mentioned task shifting, that there are various ways in which we can maybe think about delivering services in a sustainable way.
Yeah, thank you. The way I will handle that is, firstly, as we conduct our research at this period, it's very important as we generate evidence that we carry along the policymakers. So I will say that since we will be doing health system research, and it gives us, there is a part of health system research is engaging with policymakers so that there is some kind of buy-in into what we are doing. And then, of course, very crucial, we need to pay attention to issues of health information system, which is the foundation in decision making across all health blocks. So with all this, and then it would not be too much problem giving evidence for this to continue. And then more importantly, what we are doing now, continued generation of discussion is going to help to keep the momentum so that scholarly discussions continue to keep the agenda on the, to keep this on the agenda of funding bodies.
Yeah. So this business of research communication, we also need to think about communicating with the public. Now, Ed, you of course have written not only for an academic audience, you've also written for a public audience. And I wonder if you have any insights, because it strikes me that especially with the neurological, the brain research, there is the potential for some quite alarming messages to emerge. I wonder if you have any thoughts on how we can frame the findings of research so that they communicate accurately and with an appropriate level of risk, but don't add to the sort of stress and anxiety which Emily was talking about.
Yeah, well, I mean, it's an interesting question, Niall. I mean, what I think about COVID is that we're all still trying to work out what it is. I mean, we know it's a viral infection, but and we know it's already had a devastating effect. But certainly over the last several weeks, almost every other day, I've read a news story or found myself taking for granted some new development, which in normal times I would have thought was completely outlandish or impossible. So I think it is still a very protean sort of evolving thing that we're trying to understand and deal with. In terms of how we can try and communicate that to a wider public, I mean, I think that the risk of saying something rather simple, I think it's incredibly important just to talk about it. And going back to the question of what can we do for mental health research that's urgent and yet not going to just contribute to a lot of small-scale random studies. I mean, I think simply talking about mental health in the context of COVID at a time when the media focus is mainly on ventilators and PPE and the most severely ill people in the acute crisis is really important. I think it's important also, and this is not a there's the two other messages that I think are really important. One is trying to sort of convey to people that, to use a phrase that has been bandied around quite a lot recently, this is a marathon, not a sprint. So, you know, we can anticipate that some of the mental health outcomes are not visible to us yet. I think when the economic impacts of COVID really bite, and when we see what the full extent of the pandemic will be in developing economies, I think, you know, that will evolve our understanding of what this means for mental health. So I think we've got to take people with us. We're sort of experts in the sense that we've had some background training in some of the relevant sciences. None of us, I don't think, can claim to be an expert in the mental health of COVID. We've never contended with this before. So I think we have to take people with us and say, you know, there are some things we know, there are some things we're concerned about, there's a lot we don't know, and we need to keep on this for some time with mental health. We need to make sure mental health's on the agenda from the outset. We need to stay with it over many months and years to come, because the impacts might be delayed. The other thing that I would say, which is just a final point, is let's not forget what you might call the upside psychologically of COVID. You know, we've all seen examples of altruism, of people stepping up to take on new responsibilities, of dealing with their friends and neighbours in a slightly different way as a result of COVID. Maybe it makes us kinder, or could make us kinder. Maybe those kind of altruistic impulses to deal with the stress of COVID by engaging with it and trying to help other people could be part of you know, the resilience toolbox that will help people come through this in a more positive way. So those would be my basic thoughts. And just to sum up, you know, I think talking about it and making sure it's on the agenda from the outset, as I think we're beginning to do, I think is really important. Taking people with us on what is a journey of discovery for us all, and might go on for some time yet, is important. But also just trying to avoid it all being doom and gloom, because there's so much of that about at the moment. And I think if mental health comes along and says, you know what, this isn't just a potentially fatal respiratory disease, it could also have all these impacts on the brain and the mind, you know, it doesn't sound very engaging. I think if you can say, well, actually part of how we deal with that, how we boost resilience and come through this, maybe to take a look at some of the positive things that are cropping up in society, I think is another important way of engaging people with the story.
Thank you, Ed. Now, we're just going to run a few minutes. We started a few minutes late, so we're going to run on for just another 5 minutes here. We do have time for one question from our audience, and this is from Samuel Nadoro, who's a PhD student at the RNMH and the University of Lancaster here in the UK. Now, this question is for Emily. And Emily, I know that in the past you've looked at mental health in humanitarian settings with displaced people in Sweden. And I wonder if you have any insights into the interaction between the effect of COVID-19 and these populations who, as Samuel puts it, are already experiencing toxic stress because of conflict and displacement and so on.
Thank you, Samuel, for your question. And I'm really glad we had the opportunity to talk about vulnerable people and displaced people. People who are refugees are in that group, absolutely. For some, being in confinement may bring back memories of being in confinement and make dealing with symptoms even harder. So I think they're a group we need to bear in mind, and also a group we need to learn from and involve their lived experience. And what we really want to do, I suppose, goes back to what Lola said as well, which is find solutions. We know that the vast majority of refugees have access to phone technology. They've used it to navigate. So world over, this provides a tool that we can reach people with if they want to be reached, and we need research purposed at creative solutions to help people with the concerns they have, whether that's memories of difficult things, whether that's scheduling and information, and of course in the languages and words that and ways that people can receive it. So more hands to the deck, please.
Thank you very much. Now, as I mentioned earlier, we are also on Twitter, and people who are tweeting will probably want something to tweet out to sum up the session from each of our panelists. So I was going to ask each of you a question in turn, and this is a question which I'd like you to answer in 280 characters or less, or the equivalent of that. And that question is, how would you convince governments of the need to prioritize research into mental health and COVID-19? And I'd like to start with Mark.
I have to write a tweet like this, huh? Okay, I would say that the impact of COVID on people's mental health is vast, and that for a functioning, vibrant societies to recover, mental health has to be addressed, and for that, it needs to be underpinned by research.
Thank you. Emily.
Governments, I would say 4 things. I'd say there's no health without mental health, and COVID is paramount here. Governments, I'd say listen to your people and include people with lived experience. They don't always have the strongest voices, and we need to all rally together to get those voices heard. Governments do this for now, but future generations take a longer term perspective, not just a short term of office perspective. This is really important for our societies across the world. And critically, governments, science and research has solutions at hand. We want to rally together. There are solutions. We need to learn about what's helping people and turn what's helping into the out-of-the-box solutions that can help many more.
Thank you, Emily. So, Ed, do we still have you on the line? Okay, I think we might have lost Ed. Lola, what would you say to convince governments to fund research into mental health and COVID-19?
Okay, so Mark and Emily, they've addressed what we could do in the now. So I will talk about what we could do as time goes on. So governments will need evidence. So 2 issues are very vital in our research.
Okay, this is a tweet. This isn't a Twitter chain, Lola.
Okay, okay. So policymakers are involved at relevant stages of our research. And then we pay attention to health information system so that we have evidence for policymakers.
Thank you very much. And so I'll give the last word to Charlene. Charlene, how would you convince governments of the need to invest research in this area?
Okay, I'll put a money spin on it. So the economic benefits of prioritizing research in this field will far outweigh the cost of not generating evidence now, to ensure that the mental health systems and community-based structures are geared to effectively deal with the mental health and well-being of people towards sustainable development.
Thank you very much. I noticed we've got Ed back, so we do just have time for you, Ed. I was wondering if you'd give us a Twitter-length statement on how you would convince governments to fund research into mental health and COVID-19. Okay, I'm sorry, we've lost Ed again. So what I'll do now is just wrap up by thanking all of our panelists. Thank you very, very much for your contributions. It's been a great discussion today, and the recording and the notes of the session will be published on the unitedgmh.org website very, very shortly. Now we have another session, which is at the same time on April 28th, and that's on what funding is available for mental health and where. You can register at the unitedgmh.org website, and you can submit questions in advance of the session. And finally, for those of you who are interested in working with young people and or mental health in the workplace, Wellcome has just announced a new call which asks people to nominate just one approach that they think might be among the most promising for preventing or addressing anxiety and depression in young people in the workplace. Now you can find more details of this at the Wellcome's website, or you can email mental health, all one word, mental health @wellcome.ac.uk. So please do drop them a line. But for now, thank you very much again to all of our panelists. Thank you very much to everyone else who is with us on this journey. So that is United GMH, MHPSS, and the Mental Health Innovation Network. And of course, we acknowledge the support of WHO. Thanks again for joining us this time, and we'll see you for the next session. Goodbye.
Bye. Thank you very much.
Bye. Thank you. Hi, Lola. It's lovely to meet you.